organized by IMU alumni, right? So it is 8:32 p.m. As mentioned earlier, we will start now. Yeah, welcome everyone. My name is Jan Yang. I'm from DT113. I will be the moderator for today's session. So just some house rules. All participants are reminded to turn off your video and audio. But to make this session more interactive, Dr. Naveen mentioned that throughout the session, if you have any questions, you can leave it at the chat box, or alternatively, you can raise your hand and we would unmute you at the right time. All right. So before we start, I'd like to take a few moments to share a bit about our IMU Alumni Portal. All right, let me share screen. Yeah. Yeah, so I hope everyone here have registered for Alumni Portal, because that is the prerequisite to participate in this webinar. But just in case, right? Just in case for those that has slipped through, or for the final year students, you have to go to this alumni.imu.edu.my to register. So just click at the register and follow the instructions there. So this is a relatively new platform, so it will only be better things from here on out. So at this point in time, there are many benefits for being an alumni. So including certain membership privileges where you can get exclusive discounts, and also some job vacancies. If it can gain enough for following, then this would actually entice the employers to post their perhaps the dental job vacancy here, so that IMU alumni can actually have the VIP access to it. Right. Yeah. So I just want to do a short survey over here. I just want to ask, how many of you have registered with the Alumni Portal? If yes, just put a 1. And for those that haven't, no judgment, no worries, put a 2. And for students, you can put number 3, just to let us see the response. Okay. So far, so good. I'm not seeing 2. If there's no 2, Dr. Naveen means this works. Okay, great. Thanks for the response. I think I'm seeing mostly ones here, and I'm sure there's a lot of dental students too.
Danyang, maybe we can mention to them about the incentive that we can hold a really big event if many of them get onto the portal.
Oh, regarding the thing we are getting one, is it?
Yeah, if we reach the target.
Okay, yeah. So actually we have this target to reach, where if we reach 50% of our dental graduates, so we will be given a certain fund that can allow us to do much more activities. Yeah, I also forget to mention that being in the Alumni Portal actually give us, again, some exclusive access to dental events. So this is being one of them. And if without the pandemic, there's actually some workshop in the pipeline. All right. So please encourage your friends to register, and let's make this Alumni Portal the thing that connects us all. All right. So I will move on next, right, to the session. So today we are organizing this online webinar on tips and tricks for extraction, which is a very relevant topic for dentists of all ages, be it if you are a student, a fresh graduate, or even having years of clinical experience under your belt. Extraction is probably, or to me at least, one of the most nerve-wracking procedure, no matter how many times I did it. And so to allay the fear, we have Dr. Naveen with us today. So everyone knows who Dr. Naveen is, but it will be a disservice to his achievement if I did not introduce him properly. So Dr. Naveen obtained his BDS from GDC Bangalore, and then his Master of Dental Surgery in OMFS from SDM College of Dental Sciences, Dawat, India. After that, he worked as a faculty member in his alma mater for 5 years. He then completed his cleft and craniofacial surgery fellowship from SRMC Plastic Surgery Department. He was a visiting scholar at the Linkou Changgong Memorial Hospital, which is one of the largest hospitals in Taiwan. And after that, he joined IMU since 2014 and had a stellar 7 years of educating the best minds of dentistry, which in that case are the audience here today. So Dr. Naveen is also the alumni coordinator, OMFS coordinator. And you know how people always say that if you are a jack of all trades, then you are a master of none. But Dr. Naveen besides being a master in OMFS, also engages in many activities like basketball, cricket, and badminton. He is the advisor for IMU Badminton Club and was the vice captain for Rajiv University of Health Sciences. And for those that know him, Manchester United is his favorite club. And I think today he will be very happy because Cristiano Ronaldo is coming back. So without further ado, I will pass the spotlight and the session to Dr. Naveen.
Thank you. Thank you so much, Chanyan. And I have to say, you guys have been doing a great job since the start of the chapter and getting events like this. And I'm so happy to see everybody here. And it's like so amazing to see all the names on the chat box. It's just so good to see everyone back. Thank you for giving me the opportunity, and thank you for your introduction. It was very kind of you. Though there's not much to say there, I wish I can go on and do much more. Okay. And in today's session, if I can start sharing my screen, I would like to start. Okay. So am I audible to everybody? Janyang, could you be
yes, doctor.
Telling me that? Okay. And is my screen visible now?
Yes.
Okay, so I don't think we need to say anything more than that. I'm really, really happy to see all of you. And I thank all of you for joining in. I know we couldn't let some of them in because I think we had reached the numbers we thought we should have. And I mean it when I say I am really happy to see all of you here. Okay, so let's get on with the talk today. So does this sound familiar to you guys? When I was finishing off as an intern, this is exactly the scenarios I faced. So I'm sure you have had many scenarios like this. So I hope to hear from you. So if you have any scenarios other than this, put it down in the chat box so that we can address your individual scenario as well. So grossly decayed teeth, I used to hate them, especially upper molars where they look like a volcanic crater. You just hold and it breaks. I used to hate that. And I didn't know how to remove the remaining part. And there's also a scenario where you hold on to a tooth with the forcep and it starts crumbling. It's like just like chalk. So in that case, it could have been root canal treated, or maybe a tooth with abrasion and the patient had some issue and things like that. So this is another scenario, again, I used to be so scared of. And then you have another scenario where you apply so much force and you're almost tired of applying force. You think you might break bone, but then the tooth is not still moving. So these are all the situations we, I think, commonly see and experience on a daily basis. So even though this happens, we are supposed to get the tooth out, right? We are expected to get it out. So we are today going to discuss how to get these kind of teeth out, okay? So let's start with thinking about what makes extraction easy, okay? So are there extractions that are easy? Yes, there are. And it doesn't have to be a loose teeth to be easy. For me, the tooth which, or extraction case which is easy is the one in which you know what you have to do. So if you have a plan and then everything goes to plan, that's the one that's easy. Okay, so to get to that, what do you have to do? Good examination and radiograph. Okay, a very good examination or assessment of what the tooth and how the tooth is. Okay, and then the other factors which I'll get to, and also a radiograph. I know many of you, I speak to many of you, and I understand that when you work in the government clinics, you probably don't have radiographs. But then this is something for you to practice all your life. So a good radiograph makes everything easy. And then I always say this, when you do any kind of surgery or extraction, you have to have a plan in mind. You can't just go in and do something and then try to follow up on whatever happens. And obviously the knowledge of all the techniques, you should be well read. You have to know your anatomy and the techniques. Okay. And you knowing all this and doing all this doesn't make it easy. One thing which I have learned over the years is that both you and the patient have to know what to expect. So when you see a case, You tell the patient it's going to be very easy and then it ends up being difficult. That's not an ideal scenario. So you just tell the patient what is realistic, and when you both know what to expect, even the difficult cases will be easy. So the other things which the patient factors makes it easy is a young patient. Obviously, we all know why a young patient, the case is easy. It's easy because the bone itself will be much more easy to work on. That means the bone is softer. Okay. So when the bone is softer, when you try and make your movements, the tooth comes out properly. And then obviously, if there's a good amount of crown structure, again, it's easy for you. But this is becoming more and more rare because more patients want to save the tooth till the end. So most of the times we don't end up with proper crown structure. And then if there's periodontitis, it's like a bonus for us. Obviously, there's bone loss, and then we don't feel it's very difficult. One thing which we don't look at much is how wide the PDL space is. So from today onwards, when you look at an X-ray for your extraction, start correlating the width of the PDL space to how easy your extraction is going to be. Okay, a wide PDL space on your X-ray always will tell you this might be quite straightforward. Okay, and obviously for me and all of you, I know this always will be in the back of our mind. So if it's a patient without any significant medical history, you can give how much ever anesthesia you want, and then you can take a longer duration. And also, it's also in your back of the mind that the patient has no medical history. Okay, that gives you some kind of peace. So all these things make extractions easy. Okay, so there's some factors off the ball, like in football, how there are factors which affect you even though you don't have the ball, like the run you make. Okay, so what are those which are off the tooth here? Is the operator and patient position. For people who have worked with me, all of you, you know I don't like sitting down and working, because I always feel that, especially for the posterior teeth, you need that amount of force, and the physics don't work well when you are seated. But even if you're seated, please make sure your position and the patient position is comfortable for you. And the patient position, especially when you're working on mandibular teeth, the occlusal plane has to be parallel to the floor. Okay, and the level of the patient has to be below your elbow. And when you're working on the maxilla, make sure the level of the patient's occlusal plane is just above your shoulder or shoulder height. Okay, and then the chair is at an angle such that the maxillary occlusal plane is making an angle of 60 degrees. I mean, you might think, why is it so important? Start doing this. You will see that this is very important, and this will make things easier for you. And I can't stress enough on how good or how easy a proper local anesthetic makes your job. If the local anesthesia is working, the patient is not complaining or not feeling anything, everything seems to be easy. And later, we will talk about a few questions few of you have asked, in which you asked me to talk about a few local anesthetic techniques. Okay, and there are other factors which make extraction difficult, and this I can't blame you or myself. This is the patient factors which is not under your control, and many times we seem to overlook these things. First is the mouth opening. If a patient has big mouth opening, everything again seems to be easy. But if it's limited because of infection or TMJ issues, or the mouth itself is small, again, your job is going to be difficult because the instruments also can't go in. And one more thing I've started to see affects your work is the BMI of the patient. If the patient is quite a big sized person, this almost seem to have a big cheek and tongue, and makes it difficult for you to use instruments. And if the patient sometimes is so big, you actually can't even work around the patient. You almost feel like you're standing away from the patient and working. Okay, so, and also there are few anatomic variations of the tooth, bone, and things like that. So those again are not under your control, and then they make it difficult for you to work. Okay, so I mean, if it was face to face, I would have asked you guys how many patients, how many of you think that these are very important factors also. So even for me, I feel a patient who's anxious, or patients are tender, be it the husband or a parent or the son or daughter who comes with them, they act very anxious and difficult it kind of makes everything more difficult. Okay, so for me, these two I can't control. I put question marks for this because I think anxious patient, you obviously over time know how to deal with it. You have to make sure you talk to the patient, explain everything to them, and if it's going to be difficult, explain it's going to be difficult, but in a nice way. Don't use like terminologies which might scare them. So once the patient is comfortable, your locals working, everything seems to go and fall in place. And then there are factors you can control. This is where I take nothing for granted. Even today, when I do a case, I go back to the basics, like how I read it and like how I've been taught what to do. Okay, so bad technique, like I said, proper position of the patient and yourself, or just using different motions, like you rotate a tooth which is not supposed to be rotated, or you try to pull the tooth out without any apical pressure. So these things nobody can teach you. This one you have to know you're doing it wrong and you have to correct it. So how can you do it? Either by attending talks like this, or the way I learned it is by watching how my seniors do. Obviously, you'll have seniors who you think are doing a good job. It's always good to go and watch what they're doing. Okay. And a bad lighting. You always have an assistant. If you don't have one, you yourself use the lighting available, whatever lighting you have, because as long as you can see things well, things will work out for you. And another thing is bad instruments. Again, for people who are working in government clinics, I understand that there are limitations in this, but once you have your own practice, please invest on instruments. These instruments are so unbelievable. Whatever you thought are difficult situations will be very easy situations if you have the good instruments. Have good instruments with you. Okay. And then again, I'm coming back to planning and preparation. Okay. Any case, you have to have a plan. If it's a difficult case, you have to have a backup plan. Play it in your mind. And then you see everything is easier for you. Bad assistance also is something which you can encounter if you have assistants on rotation. Okay. Luckily for us, we have been staying in one place for long, and do understand that assistants know how the doctor is. Okay. So if they know that you are a certain way, they will work in that way. So you can be different outside, but when you go into that room where you do your surgery, if you're different, they know they have to do their job well. And you can slowly tell them what your preferences are. You don't have to stamp your foot and be rude to them. You can politely ask them what is your preference and keep telling them what your preference. And if you politely tell them and they see the cases are going well, they'll be more than happy to help you. But then bad assistance, if you are complaining about it, I think that's something you can control. You should work out and be a team player and work with your assistants and make them understand that they are part of the treatment. Bad assistants really can be something which spoils every case for you. Okay, so these are the general factors, and everything I talked today, I talked from my experience. There's nothing I took out of a book. This is all what is in my mind, and I put it out in front of you guys today. Okay, so the next part of my talk, I'll be talking about different teeth and the challenges. Okay, so I'll go from incisors posteriorly. So now what you can do is put in the challenges for whatever teeth you've had, and then we'll try to address it in between or later. Okay, so I've just put in the challenges which commonly arise. Say you have anteriors. Okay. History of trauma, the age and all that to determine its fracture, right? But many times you end up having teeth like this. I hope all of you can see this, where this side is the buccal side, and then you have the palatal side here. So imagine this is a upper incisor. So what you see here is there's tooth structure at the level of the bone. Okay, and these cases, many times I've seen people struggling with this. So what's the best method to remove this tooth? Obviously, there has to be some bone which is to be sacrificed. Okay, so you can't get this tooth out unless you sacrifice some bone. So you have to think of removing this bone. Okay, so this amount of bone has to be removed so that you can at least engage your forcep there. So what does that mean? Do we have to raise a flap and then take a burr and drill that? I don't think we'll do that in these kind of cases. When you see something like this, there's something more easy which you can do. What you can do is raise the flap properly. And when I say raise the flap, you have to go in, use your periosteal. You don't have to give any release incision. And then at least till here, you need to raise the flap. Okay. Once you've done that, you can engage your forcep. Once you've done that, you can engage your forcep. So like this. Okay. So you don't have to take a drill and drill the bone. You actually hold the forcep over the bone like this. Okay. So once you hold like this, your intention should not be to pull out the root. One of the main mistakes which we end up doing is, as soon as we hold, we try to pull in this downward direction. Okay, we try to pull in the downward direction. We should never do that. So as soon as you do that, again, this part of the tooth might fracture. Okay, so what you have to do is just hold and then try to crush the bone. Try to crush the bone and then you give a palatal tilt. Okay, one thing I always tell everyone is the tilt you give for a grossly decayed tooth should be always towards the tilt you give should always be towards where the tooth structure is less. So in this picture, you see that the tooth structure is less on the palatal side. So you give all your tilts on the palatal side so that the engaging beak of the forceps goes deeper and deeper on the palatal side. Okay, I hope that's making sense to you. So in this tooth, don't try to pull out or don't try to give buccal tilts. You start giving palatal tilts. Once you give palatal tilts, your beak on the palatal side will engage deeper and deeper, and then it will give you some grip and the tooth might start moving. And once the tooth starts moving, you can rotate it and remove it. Okay, this is the way you have to do. Even say for premolars or molars, you can use this rule. Don't forget this. Whenever you think that the tooth structure is less on one side, give the tilt on that side. Okay, for example, here it's the palatal side. You give more tilts on the palatal side until the tooth starts moving. So if somebody is not understood this, please put this up on the chat box. I'll tell you again. But just remember, tooth structure is less on one side. Your tilt should be more on that side. Okay. And what about canines? Let me just change. Okay, what about canines? Canines normally don't trouble you much unless it's a long-standing canine. It's been there for a long time. Otherwise, it doesn't trouble you much. What movements do you use? You can use buccal and palatal movement with rotation. Okay, so the ones which trouble you normally are the ones which have roots like this. Okay, so if the root is bulbous or big, or the root tip is larger than the rest of the root, these are the ones which trouble you. So in that case, you have no choice other than to raise a flap like this. So you see the flap here. You raise a flap. When you raise a flap, please make sure you go at least one tooth beyond the tooth that you're working on. Okay, that's the rule. When you raise the flap, at least one tooth beyond the tooth you're working on, and then you have to then drill the bone. So how much bone do you have to drill? Sometimes all the way up. Okay, so all the way up, and then you try to extract the tooth. So the other challenging cases when it comes to canines are when you try to extract and then you might have a buccal cortical plate fracture. Okay, the cortical plate itself might fracture. So in that case, what do you have to do? You have to do a primary alveoloplasty, because you'll have a big area of the socket which is exposed, and there'll be two sharp bony margins. So you can't leave it like that. You send the patient back, they'll surely come back with some or the other problem. Okay, so better you make sure you do the primary alveoloplasty, put the flap back, and then check, and then send the patient. And then you can also ask the patient to massage the area after a week. Okay, before that, you don't want him touching the area, him or her touching the area. Right. So I want to know if everybody understands the difference between a premolar forcep and an anterior forcep. Okay, I was surprised when I talked to students how many of them still don't get it. Okay, it's very easy. So these two here are premolar forceps. So this is the upper premolar forcep, and this is the lower premolar forcep. And here you see are your anterior forcep. Okay, these are the anterior forcep. The main difference I look for is the gap between the beaks. Okay, I look for the gap between the beaks, and many times assistants will not know this. Okay, so you have to mention to them that this is how you differentiate. And when you use these for premolars, make sure you see that gap, and you be assured that this gives a much better grip. You might get away by using anterior forcep, but then the one with gap will always give you a better grip. And many of the premolar forcep these tend to become loose over time. If you hold the forcep, you can actually shake them like that. If they're loose, then again, when you grip the tooth, the force won't go. So check for that. It has to be firm and tight, and then you can use them properly. What about premolars? What challenges do we have with premolar? So it's not uncommon for you to see these dilacerations or curved roots. Okay, so if you have something like this, what can you do? What I do is I do like a normal extraction, but obviously I would have told the patient that there is a chance of root breaking, and if it breaks, I have to open up. This is already on my consent. Yeah, this won't happen after the root is broken. I've already written it down: extraction or surgical extraction of this tooth. So one thing which makes it easy is extract it normally, but while doing it, luxate it and use the forcep, move it buccally, palatally, and also keep rotating it. Okay, you might be wondering, he's saying it will break and he's still trying to do all this. So the idea is, even if it breaks, if you've done all this, the root might be slightly mobile. Okay, and a mobile root is much easier to remove than a firm root. So if you just hold this tooth and break it, and then the broken part of the root is inside and stuck like that, it is going to trouble you. So if it's mobile, then your chances of retrieving is more easy. Okay, it makes it an easier job. So when you see this, be very slow, keep expanding the socket, keep moving the tooth, and then finally, if it breaks, it's okay. You knew it will break. Okay, and then another case, like the case of the drawing you saw for the canine, you can see something like this. So if the tip of the root is larger than the rest of it, then you can be assured that this will break. Okay, this will break, and this will act. You have to make sure you raise a flap, and then you remove all the bone. You remove all the bone around, and then you can remove the tooth. Okay, otherwise this one won't come. So this, you can't help it, it will break. Okay. Next, we go on to your first premolars. Okay. These have two roots, like you know. So most of the times, if the roots themselves, but the bifurcation is very high and you are not gentle with your movements, one of the roots or both the roots can break. Okay. So the higher the level the root is broken, the easier the retrieval. The higher it goes, the more difficult it goes. And one more complication is that many of your premolars you extract will be orthodontic extractions, where the orthodontist would beg you not to break the tooth. Okay, so he's begging you not to break the tooth, so you have to be very, very gentle with that. So what can you do when the root breaks? So if only one of the root is broken, what we can do is use the other socket as a space to engage your forcep. So you can engage one beak of the forcep here, one beak of the forcep here, hold over bone like I have shown previously, crush the bone on both sides, and then remove the root. That is if it's broken at a high level. Okay, if it is broken at a very high level, then you can do that. Say it's broken here at this level, but then if it's broken here and it's an ortho case, you can't do that. Okay, that will be very wrong, because your orthodontist will not like you removing any bone. So what you can do is you can actually create a window here. You can create a small window, raise a flap, and then create a window, and then you can push that root through the socket. Okay, you create a window here, and then you push the root through the socket. But then for this, you have to raise a big enough flap so that you can reach the periapical area. So the other option is to remove the whole buccal bone here. Okay, so better than that, you just make a hole here and you try to push the remainder of the root. So we have done this many times. That's why I'm giving you this option, and it is quite easy, especially if you have taken time to luxate and mobilize the tooth. Then the root will be loose and it will actually pop out. Okay, so the good thing is it has two sockets, so you can use one of the socket and then either put the forcep and try to take it out, or if it's a very small piece, then you try make a window, or if you have no choice, it doesn't come out through the window, you have to remove all the buccal bone and then remove it. Okay, so you also have to watch out for the sinus coming down. Okay, especially in the maxillary posterior region. So the sinus can really come down when there's long-standing edentulous areas. So you just make sure you watch out for that. So if there's long-standing edentulous areas, again, it's best to take a PA and check, and watch out for the lamina dura. If there's intact lamina dura, then it means the root obviously is not in the sinus, and most of the times it is not, unless you give excessive forces. Okay, so if you see an intact lamina dura, even though the sinus is down, you are safe to do the extraction. Okay, what about lower premolars? For lower premolars, you can again have hypercementosis like this. Okay, so when you have hypercementosis, again, no choice, you have to do a surgical removal. Okay, you try to do it normally, and then obviously it will break. And if it breaks at this level, even though you remove all this bone and try to push this, sometimes it becomes like a ball and socket and keeps rotating inside. Okay, it keeps rotating inside. And for anybody who's doing extractions, going all the way down here and removing all the bone, you feel very bad, but then you have no choice. So one of the other things I've seen is, even after removing this much bone, sometimes the root keeps rotating. The root keeps rotating. So what do you do in that case? You ask, you take a periosteal elevator or a thin instrument, you stabilize the root. Okay, you ask somebody to stabilize it there, and then you just section it. Once you section it, one can come out, and then the other one obviously is very easy to come. So not only in this situation, in any situation that a tooth or root is stuck and it's rotating in its own socket, the thing you can do is try and section it off. So once you section it, you obviously can get one piece off followed by the other piece. So, and this area also, you have to be very careful where you place your release incision, because many times you get carried away and forget where the mental nerve is. So your release incision in this region should never be in between the premolars. Okay. And if you are putting it in between the premolars, you better know where the mental nerve is. So when in doubt, just go away from in between the premolars. Don't have your release in between the premolars. Okay. So again, you can have supernumerary teeth like that in the lower premolar area. It's not uncommon. I see a lot of these, and you can see here. So in this case, what can you do? You can't do much. And if you just have a 2D IOPA like this, you really don't know what's the relationship of each root to each other. You could guess from the direction in which there are, but it's very difficult. So for these cases, what I do is take a CBCT. Firstly, see if it's really needed. The complaint that the patient has when they have teeth like this is mostly food getting stuck. So many times if food is getting stuck for a long time, they already have periodontitis and bone loss. But you can see in this case, there's no bone loss and the patient has pain, already undergone root canal therapy, and now he wants one of them removed. Okay, so I'll definitely do a CBCT in this case and then take consent from him. What consent will I take? Consent for damage for adjacent teeth if the root relationship is very close to the other tooth. Okay, there are some teeth which are lingual, but the root goes all the way towards the buccal cortex. Okay, so unless you see on CBCT, you won't be able to appreciate that. So you see, again, a case like this where it's stuck inside, obviously you see there's no bone there and he wants to get it off. So in this case, again, it'll be very helpful to have a CBCT and take consent, right? You explain everything to the patient. Right. Okay. So let me check with you guys. Are there any questions till now? And is there any other situation you've encountered while you're extracting anteriors and premolars? Chanyang, is there any question till now?
Yes, Dr. Naveen. But I think since I'll just fill the question that are related to anteriors or premolars.
Yeah.
So there's this question from SM. Yeah, maybe
Okay.
Spider-Man, I don't know. Yeah, so his question was how to grip onto an upper second premolar with a 45-degree fracture. He means the palatal cups that is subgingivally.
Okay. 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 Let me try and draw that. Okay. So imagine this is the palatal side and this is the buccal side. So you said it's fractured palatally, right?
Yes, 45-degree and subgingivally.
Yeah.
Yeah, I think that's what he meant.
And then you have the root like that. Okay. So again, like I said, one thing you have to always know is in this case, you can't grip the root. And as soon as you can't grip the root, you already start thinking this is going to be trouble, which is true. So again, I'm stressing on reflection. Reflection is everything. If you don't reflect the palatal flap properly, then you can't grip on that. Okay. So what you can do is reflect the mucosa all the way till here. Go as far as you can. And the palatal mucosa, you can reflect. You can go to the midline. And for people who haven't seen orthognathic surgeries, we can actually tunnel through and through the palatal mucosa. So for anterior maxillectomies, we actually tunnel through and through. So you can do your reflection as deep as possible for the palate. Okay. So you reflect as deep as possible, right? And then on the buccal side, again, my reflection till there. And then I'll use a root forcep. the upper root forcep will be sharper than your premolar forcep. Okay, so if you think the big premolar forcep is too big to go deep, use the upper root forcep. Okay, and then you hold here over the bone. Okay, so you hold here over bone. Okay, my forcep is not looking great, but yeah, I hope you're getting the message. You hold over bone and you actually look. The first thing you have to do is, again, like I want to stress on this, the first thing is not to remove the tooth. Your first idea is to just break this bone. You break this bone and you break this bone with the forceps by just crushing it and putting apical pressure. By putting apical pressure, you also are causing slight expansion of the socket. Okay, so just break the bone and make sure you're just gripping the tooth. So I hope that's clear. Your idea when you do this is not to remove the tooth, just to find a grip on the tooth. You crush bone and then you have grip on the tooth. Once you have grip on the tooth, like again, I'm stressing on this. So you have said the tooth structure is less on the palatal side. So keep giving palatal tilts. So keep giving palatal tilts. What happens is, once you keep doing that, your beak goes deeper and deeper on the palatal side and it will engage over there. Okay. And once you think you've got good grip on the tooth and you've moved it palatally and you think there's some movement, start rotating the tooth. Some buccal and palatal rotation, just keep rotating it like that. And then once it's completely mobile, that's when you want to pull it out apically or buccally. Okay, I hope that answers the question. And in some cases, once you engage with the forcep, it will keep breaking. It'll keep breaking. So in those cases, you have no choice but to remove some bone. You'll have to remove some bone, make a purchase point, engage the elevator and remove it like that. Okay, so the first choice will be to use forcep. Forcep doesn't work, then you have to surgically open, trim the buccal bone and then remove that. Okay, I hope that's made that clear.
Yeah, doctor, I think that is very clear. So yeah, grip the bone and then a lot of palatal tilt, right?
Yeah.
Yeah, doctor, so the other questions are related to molar. So I think maybe you could proceed with the presentation, then we will go on to them later.
Good. So for molars, for me, this was the most terrifying, especially upper molars. If I saw a tooth like this, which was a volcanic crater, I didn't know what to do, because I know as soon as I hold it, I'll lose the crown. And once I lost the crown, I used to lose my mind because I really didn't know how to go after that. Okay, so this kind of cases, especially after becoming a postgraduate, if I ever got this, I used to go take my chair. We used to have our own chairs. So go there and spend a lot of time and try different techniques. And then eventually I got the secret of how to get these off. Okay. So these grossly decayed ones, now because now I know what to do, I'm not so afraid of them anymore. Okay. Again, this one, you see something like this. This is easier because all of them are grossly decayed. So at least you can see them properly, especially if you have all the other teeth intact and then a grossly decayed in between, then it's very difficult. So for all of you who are thinking or having trouble dealing with grossly decayed teeth like this, my only advice is just forget that there's a crown. Treat them as root stumps. Forget there's a crown, because as soon as you hold the tooth properly, if you're actually holding it properly, the crown will break. So just forget the crown and deal with the rest of the tooth. Okay, so if you have an x-ray, you really know what's happening inside. So in this case, luckily we have the x-ray, and then you have your lower molars as well. If you see something like this, you know it's very easy. You can just use your periosteal to get these off. Yeah. So what is the thing I finally realized with these molars? So I've just tried to draw that. I hope this drawing is good enough for all of you to understand. So basically, when you see this volcanic crater like that, you hold your forcep and then it just breaks. Okay, so it breaks, and then this is, if you are viewing it from top, as in the occlusal view, this is the palatal root. Okay, and then the two buccal roots here. So what I realized is all that you have to do is, again, reflect properly, and then either hold, if the tooth is slightly above bone level, or if there's bone, use this instrument. Okay. Okay, because I'm switching from writing to again changing slides. I'm just having trouble. Yeah. Okay. So this is the magic instrument for these kind of teeth. So if you try with your normal forcep, you're probably getting into more trouble, crushing it more below bone level. So what I always do is use the cow horn forcep. So we all know that this side goes palatal and this goes buccal. So what I do is I use this to just engage the tooth. Again, like I told you in the previous thing, my whole idea of using this is not to extract the tooth, to crush the tooth. It's literally to crush the tooth. So I just hold and crush. And when you crush, most of the times, one of the roots will become loose. Okay, you can try that. One of the roots will become loose. Then you can just use an elevator to just elevate it, or you can use a root forcep again to use it. The good thing about these teeth is that once you have one of the sockets empty, you can always say the palatal is come out and the buccal is still there. Okay, so you put one beak here, and then you crush the bone and you remove the root. Okay, you can do the same with this root. So your idea with multi-rooted teeth is always to get one of the roots out. Once you have one of the root out, you can use the other socket to get the other roots out. Okay, so when you have something like this, if you try using forcep and you try to remove the whole tooth using forcep, it's not going to happen in most of the cases. If it comes out, it's good, but then it's easier to do this. You try this technique and I'm sure it will work for all of you. So just take your cow horn forcep and just squeeze. Okay, a firm pressure and just break it. So once you break, most of the times one of the roots becomes loose and the loose root goes out, and then you can use that empty socket for putting your forcep there, and then here, and then remove, depending on whichever root has come out. Okay, so that's my technique for these grossly decayed upper molars. Okay, so the whole idea is to make one socket empty. Most of the times what I've seen is one of the buccal roots pops out because maybe it's shorter or it has less bone around it, and then the palatal stays back. So it doesn't matter, whichever root comes out is okay. Once one is out, the others will come out. So I've seen some people attempt to use burrs, okay, use burr and cut through this. And that's a dangerous option to take, if you ask me, because when you cut through this, you actually, if you go through and through, will be cutting through the palatal root as well. So you don't want to cut the palatal root into half and get into that situation. So a cow horn, if you know how to do this, will be easier. Or I would suggest you can just make a groove halfway to just help you use the cow horn. Okay, but for you to go and make this kind of a sectioning of this is almost impossible, given that you're looking into the molar teeth. So that will be a very difficult thing to achieve, to separate the two or three roots like this and remove each one out like that. So most of them will end up doing like this. Right. Okay. So that's about your upper molars. And for lower molars, many times when I see cases like this, I'm quite okay with that, because again, I don't consider that I have the crown. I don't bother if the crown is still there or no. Even if it fractures, it's a good thing. The earlier it fractures, for me, it's easy, because now I know what next I can do. So in this, obviously, again, I'd say this to students in the clinic, and I might have told a few of you also, I don't try using Couplan for most of the teeth, but for lower molars, I definitely use them. Okay. For lower molars, I definitely use them when the whole tooth is there also. So I try to luxate first, and then I use a cow horn. Like again, like how I used in the upper teeth, I'll use the cow horn and just break this into two. Once I know it's broken into two, I'll treat this like a premolar, and this I'll try to remove with the lower root forcep. Or once one of the root is out, what you always can do is use your Cryer's elevator. With your Cryer's elevator, you can break the alveolar bone. Okay. First, break the, I'm sorry, not the alveolar bone, the interradicular bone. And once you break that, then this one has no support, right? It has bone only that side. So you can scoop this out as well. So you can, if you can grip this, use a forcep. Otherwise, you can always use a Cryer's elevator. I don't think we use crossbar anymore because crossbar obviously generates a lot of force and people try not to use it, but a Cryer's is still okay. Okay, so this is a lower root forcep. Once I use cow horn, then I use a lower root forcep to remove the two pieces. If it doesn't come, then I use Cryer's to get this off. Most of the times, we don't have to remove any bone. Okay, so you see, same thing here. If I see a case like this, and this one infected, so there's furcation involvement, so there might not be too much bone. So it's the same sequence that I'll do. Okay, but make sure that if you see anything like this in the periapical region, just try to curate it out. Okay, just try and curate and see if there's any soft tissue or granulation tissue, you get it out. It's a good thing to do. Okay, thank you, Michelle. I think Michelle sent this, and she said that the 4-6 coronal aspect fractured, okay, due to due to caries, and she attempted sectional extraction. Okay, when she's saying sectional extraction, I'm guessing it's surgical extraction to section the two roots separately, but the burr did not cut all the way through to the furcation. Okay, so this one, and it was very hard to see because the patient had limited TM mouth opening because of TMJ pain. Please advise on how to ensure the sectional extraction to ensure complete removal of the fragments. Okay, so the roots are broken below interseptal bone. How do you create a point of elevation? Okay, so basically, this is one of your friends who shared the case. This is like real life situation which he got into. So this is pretty bad now. I think one of the things, as soon as I see this, is making it difficult for me is the mouth opening. I mentioned this in my beginning slides, right? In the slides in the beginning, that once mouth opening is limited, everything is difficult because you can't see properly, your instrumentation can't be done properly. So in this case, you should try to break this, but it's already much below the bone level. So you have no choice, but you'll have to open it up. Okay, so you have to open it up, and you can incise like this with the release over here. Okay, so a few of you might be wondering, does it matter where the release is placed? Can we place the release here or here? Okay, so it's always better you have the release more anteriorly, because for you it's easy to close or monitor later. So if you place the release here, it's okay, but then for you to probably close, it will be more difficult the posterior you go. Okay, so you can place an incision like this. Okay, and then one thing you shouldn't be scared of in at least 6 and 7, that's first and second molar, is to go deep and drill. Unlike third molars where the nerve is closed, when you section them, here you can literally go down as much as possible and drill over here with your straight burr or round burr. Okay, if you go down to the interradicular bone, it's good because your root will come out easily. So just don't bother. you go halfway, as in from top, that's what you'll be seeing. So you go and drill as deep as possible. So I'm just cutting through the tooth here because I have the x-ray, I can see. Clinically, even if you go down till here, doesn't matter, okay? Because the lesser the interradicular bone, the easier to get the roots out. And once you've done that, I don't think you can hold these teeth with forcep. So you will have to trim bone. Okay, you'll have to trim this much amount of bone. And then you ask about the creating a point. So what can you do? Obviously, now you treat them as two different roots. So your purchase point can be on the buccal and anterior part. Okay. Okay, let me just show you where you can do that. Okay, I hope you can see my pen. Somehow I can't seem to draw now. Okay, yeah. So what you can do is you can create a purchase point here. So when you're already struggling, try not to make the purchase on the tooth, okay? Because sometimes you try to drill on the root and then you try to put the elevator, it will break at that level. So what I do is I've removed all this bone, and then I just remove extra bone here. Okay, just remove extra bone here, and then we can put a elevator at this point and remove this root once it's mobilized. Okay, you put your elevator here and keep mobilizing it. If it just comes out with your elevator, it's fine. Otherwise, after it moves, you can use your root forcep to hold it and then remove it. Okay, once this root is out, you try to use your cryers, break this interradicular bone, or now you already have opened it up, so you can use the burr to remove this. Once you remove that, again, you can just put your elevator back here and push the distal root anteriorly. Okay, if it's not moving, again, you will have to use your forcep to get grip and remove it. So in this case, forcep is quite difficult. So you might have to work only with your elevators. So just remove more bone as much as possible, because it's already cut in a difficult way. Okay, it's already cut in a very difficult way. So as Michelle here, and does that help, Michelle? I don't know what happened with this case, so maybe you can tell us later. So if I found it, if I was to help out with this case, this is what I would have done. Okay, so one of the common questions, we asked you guys to send some questions. So one of the question was how to use Coupland properly. Okay, so I always see people using Coupland the right way. The right thing you do while using the Coupland is put it in between the tooth and the root and try to put it in that PDL space we're talking about. But what I see most of them doing is that the angulation which they bring their Coupland down to the tooth, right, is many times straight like that. So say we have a tooth. Okay, it's playing up again. Okay, so let's just imagine a tooth, all right? Yeah, I can't seem to draw sometimes. It's, yeah, so most of you, when I see, you bring the Coupland much more upright, okay? So if you bring it upright and try to move, it's quite difficult, okay? So try and do this next time. Bring the Coupland at this angle towards the tooth. Obviously, the concave surface of the Coupland should be towards the tooth that you're trying to extract. And then once you have it, you have to hold it in your palm and thumb grasp. If you're trying to hold it in a pen grasp, you can't get much strength out of that. Your force you generate will be very, very less. Okay, so face the concave surface towards the tooth, and then you bring this at this angle to the tooth. Okay, so if you try bring it up from there, then all that you're doing is try to expand the socket, but that angulation, you can try and expand, it won't expand that much, and the tooth won't move. When you try to use a couplant, one of the things you want to do is try and mobilize the tooth. So if you come at this angle from the mesiobuccal aspect and then try to move it, it will obviously move. And one other thing I always tell everybody is, say if you have 2 or 3 teeth you're working on and you want a certain teeth to move, place your finger on all 3 teeth so that you know which tooth is moving. Okay, so you make sure you know which tooth is moving by placing your finger on the teeth while elevating using a couplant. And the other thing which most of us ignore, okay, most of us ignore, is to support the jaw. Many times, because people unnecessarily apply so much force during elevation, the patient ends up with TMJ problems. Okay, you start wondering why is the patient having TMJ problem? It's because you applied too much force while elevating or trying to extract the tooth. So one finger over the occlusal surface of the tooth, your thumb can be supporting the jaw from the outside. Okay, so the jaw shouldn't be stretched or the TMJ shouldn't be stretched. Okay, then the patient will be comfortable as well. So one of the reasons when patient complains of pain during elevation or extraction is also because of the TMJ being stretched, and which we never think about. And we give them a problem or a disorder for life by doing that. Okay, so please be very careful. And another question, interesting question was, can I use couplant elevator lingually? In my 15 plus years of doing extractions, I have never used it from the lingual side. Maybe when the tooth is already, it's a root stump, it's already mobile and it's just, I need to pickle it out, then maybe I do that. But if I have to give my complete force and use the couplant properly, I'll never use it lingually, because I have seen 2 or 3 cases where people have tried to do this and either gone into the floor of the mouth. So they try to force it a lot, and if you ever slip, you go into the floor of the mouth, it's highly vascular, you could hit a vessel, and I've seen a lot of bleeding after that, and it's very difficult to manage. One is you don't need to do it, and if you do it, there's chance of either going into the floor of the mouth, which you don't want to do, and also because you're going over the other teeth from the other side, you might just injure some other teeth as well. So can you use couplant lingually? I don't think you should be using it from the lingual side. You will do more harm than good. So all that you have to do is use it from the buccal side. It's safe like that. Okay. And another interesting question is, I think, how to give an effective inferior alveolar nerve block. Okay, so this one depends again on many factors, and it's good you asked me this, because even to this day, if I treat 100 patients, maybe in 10 of them, I struggle or I might have to give a second inferior alveolar nerve block. So one thing I've learned over the years working with many surgeons, especially here with Dr. Chris, is understanding the anatomy. So if I show this now and I ask you which one is the coronoid notch, I don't know how many of you can tell me that. Okay, and if you all know which one is the coronoid notch, I'm very, very impressed, because I for one didn't know what's the coronoid notch for long, because this one is the sigmoid or the mandibular notch. Janyang, is my arrow visible?
Yes, doctor, I can see it.
This one is called the mandibular notch or the sigmoid notch. Okay, so for many years, I used to think this is the coronoid notch. That's me being stupid, but I'm accepting that. Okay, and then later I got to know what the coronoid notch actually is. So coronoid notch is the deepest part over the ascending ramus. Okay, so if you want to give an effective IANB, for me, the most important thing you have to know is the skill to see which is the coronoid notch. Okay, most of the times it's 5 millimeters to a centimeter above the occlusal plane. So why is it so important? This is the height at which you need to inject, and that's where the nerve is getting into the mandibular foramen. So what I've even taught the students in the previous LA classes in DSE yesterday and day before is that you always start palpating for the landmarks from the sulcus, maybe next to 6 or 7. So try this next time in your practice. So you try palpating from here, and then many times a few of the surgeons I've worked with talk about internal oblique ridge and external oblique ridge. I don't think your tactile sensation can be so good that you can appreciate all this unless you have been doing this and you're a max fac who's opened up and seen what's inside. Okay, so for me, I always palpate for 6 and 7 and just go up the ramus, and the ramus is more lateral than you think. So if you're too medial, it's probably the internal oblique ridge. Okay, you're probably touching some area here. So then if you're somewhere here, then what you think is the notch is not the notch. So the most lateral aspect is what you need to try and palpate. So palpate the most lateral aspect of the mandible, and whatever is the most concave aspect of that is your coronoid notch. So if you find that, and at that level you can go and inject, then your block works most of the times. Okay, so if you've been doing anything differently, try and do this, and then do let me know if this works any better. Okay, and for the lingual nerve, before coming to Malaysia, we used to move the whole syringe kind of laterally, as in over the teeth, and then inject. But then after working here, I've realized just retracting it slightly is also enough, because the lingual is medial and anterior. So by doing both, you're doing the same thing. So I inject for inferior alveolar and just retract slightly to inject for the lingual nerve to block it. So if you have anything more you want to know about this, you can let me know later. So that's how I get my inferior alveolar nerve, and I'm much better than when I started off, after I started doing this. Okay, and then another interesting question was how to give effective intraligamentary. One of the questions is it actually required? Many times it's not required. If your nerve block's working well, you don't have to give, or your local and infiltration works, you don't have to give. But I use this sometimes if the patient can pinpoint the pain to around the tooth. Okay, so then what's the intraligamentary? It's very easy. You have to go into the PDL space, okay, and then try to inject. So where do you inject? So you actually inject like that in at least 2 or 3 places, and you actually can see the blanching of the gingiva as well. So you give mesiobuccal at the center, distobuccal, and same for your lingual side. Okay, so you just go into the gingival margin as deep as possible. And one thing is, this is again like giving in your palate or even harder. So you try to push in, it doesn't go very easily. That's why you have all these computer assisted devices to do this. Okay, so where they sense the pressure and do this. So if you do it manually, this is much difficult to inject compared to your local on infiltration or nerve block. But it does help in some cases when the patient has more pain after your other injection techniques. Okay, so let's move on again with your lower molar teeth. So again, if you see something like this, then you obviously know it will break. So again, like I told you before, I'll repeat. If I see a case like this, I'll tell the patient, I know this might break, but I'll make all the effort to try and expand the socket slowly. So for whoever doesn't understand expansion of socket, you have to start believing it's a real thing. So sockets do expand, the periodontal ligament does tear, and that's why you can remove the tooth. So keep working on it. So what I'll do in this case is keep using the forcep and do my buccal and lingual movements and try to rotate along the long axis. Okay, so I keep doing it, and then if it breaks, again, I'm hoping that the roots are loose because of all the movement I have done. Especially for you when you don't have x-rays and you have 20-30 cases waiting. I know you don't have the luxury of doing that. Take this as an advice for your own practice later on. The patients really will appreciate that. Okay, so let's move on to mandibular third molars. Okay, for mandibular third molars, these are very interesting. Most of them don't have to be extracted if they're okay and in occlusion, but if they're troubling, then you need to get them off. They could be carriers or impacted. So today we won't discuss impacted mandibular third molars. We just talk about normal extractions. One of the things I've seen is, especially when you're starting off in your junior days, you tend to think that if there's just a soft tissue cover over the mandibular third molar, you can just elevate and get away with extracting that. It can happen if there's no bony impaction, if there's no bone cover. So at least for mandibular and maxillary third molars, you have to have x-rays. I agree for other teeth, maybe you can try without doing them and you get into trouble, you can take x-rays. Okay, but more and more for legal aspect also, for any extraction, x-ray is needed now, because again, like I said, patients want to save their teeth. So unless you have an x-ray, you don't have a proof that the tooth needs to be extracted. So in any case, for third molars, maxillary or mandibular, x-ray is advised. Okay, x-ray is almost the most important thing. Okay, so even if there's soft tissue cover, some might not be impacted and you can just do the elevation using a couplet, but please make sure you have one x-ray before you do that, because in these cases, if you get into trouble, as in if there's a root fracture, you really won't have plan B if you have not seen the x-ray. Okay, so for me, elevation is a key for mandibular third molars as well as maxillary third molars. So when I'm doing the mandibular third molar, if it's not moving with my couplet elevation or luxation, then I know I'm in trouble. So I just won't go in and use my forcep and try and break it. What I'll do, I know with that amount of force and luxation it has to move, it's not moving, then I just open it up, remove some buccal bone, and then use the forcep. So this forcep here is called the American third molar forcep. I'm sure all of you know. I seldom use a normal lower molar forcep for my third molars. Okay, because the cheek is there, and with the UK pattern or the British pattern forcep, you can't reach that properly. Your angles are not right. So I always use the American third molar forcep once I've got enough movement in the tooth by luxation. Okay, so what if a root is cut like this? So say you don't know what you're doing, you just attempt and break like this. Obviously, you have to open up. And once you open up, it's very, very difficult for anybody, even for people like us who have a lot of experience. Something like this will be a very difficult case to manage. So again, we'll have to raise a flap, okay, like that, and then drill bone all around till here. Okay, so I have to learn how to use this, because so every time I need to go back to the pen, I guess. So remove all the bone here. In this case, I guess we'll have to remove much more bone. Okay, and then the common mistake while removing bone is that we end up not removing bone here, and this ledge can make this get stuck. Okay, so the bone distal to 7 is where you don't remove, thinking you might enjoy the 7, which is actually the reality. But unless you remove that ledge of bone, your root won't come out. Okay, so you remove the bone properly, and then you put your elevators and try to get this tooth out. Okay, so that's how you'll do that. So you also have cases like this. So if this was referred to me after this was broken, I will straight away do a CBCT to see what the relationship is with the canal. Okay, otherwise I simply won't dive into this, because I know I'll get the mesial root out, but I might be into trouble while dealing with the distal root, even though Once one root is out, the other one is easy, is what I've been saying. In this case, I would take a CBCT and see what's the relation before I go in and do anything. So that's about your mandibular third molars. So for that, my message would be to just luxate it properly. If you can luxate it, it's probably coming out. It doesn't move with luxation, then you might be looking at surgical removal. Okay. So what about your maxillary third molars? Okay. This one can sometimes finish in 2 minutes or sometimes take 2 hours. Okay. There've been interesting experiences for me with maxillary third molars. Okay. Sometimes you just take a Warwick James elevator and just push and it's done. Sometimes it just troubles you a lot. Okay. So one of the questions again sent to us was how to extract using Warwick James. Okay. So for people who don't know or who don't use, this is Warwick James. It comes in a pair, which is for the right and left side, and also a straight one. Okay. So I prefer this over cryers. There are people who use couplants and cryers to remove third molars. I don't like couplants. I don't like cryers even more because I've seen too many tuberosity fractures when people use cryers for elevating the tooth out. Okay, so if it's not happening with Warwick James, it probably needs some bone removal. If you use cryers, which gives you more force, you're probably removing the tooth with the tuberosity. Okay, so that's not a great thing to do. And couplants, I think it's just too difficult for me to go in that area, especially like I told you, in some patients who have a thick cheek, if you can put it like that. Okay, so the main thing with maxillary third molars is access and visibility. If it's accessible and visible, we can get it done. Especially when it breaks, it's very difficult because the 7 and the cheek are all blocking your visibility and the access. That's why it's so difficult. And I say, take an X-ray before that. So some of them are like this. So you can see a single fused root, conical, and then they have a nice distal bend to the root. So in this case, you take your Warwick James, you put it here, the concave surface over here, and then your movement should be distal and down like that towards the occlusal side. Okay, distal and down, and you have to just use your wrist and push, and then it'll be out. You just don't need your forcep also. Similarly, in this case again, so you have to know which one's right and left. Obviously, the concave surface again goes here, and this one, the root is so nice, fused, distal curvature, which is the best for you, and then it just comes out in no time. Okay, and one other thing you have to look at in your X-ray is how much distal bone is there. Okay, if you see here, the distal bone is at the level of the CJ, but everything else is easy, which is like the conical root and the root pattern and the direction. And in some cases, even though it's broken, the distal bone level might be very low. And in these cases, again, you can get it off easily just by using forceps or elevation. So look for distal bone, the amount of distal bone when you do your upper third molars. Maybe now you don't know this, but from now on, look for that. Okay, so if you have a grossly decayed tooth like that, you still have some mesial tooth structure left. You just go in as deep as possible, push, and then if the tooth starts moving, you push the Warwick James more apical and apical. Okay, so you keep doing that and you keep pushing, and then it comes out. Okay, so one thing you have to understand is each tooth has a path of removal based on its root pattern. Okay, so if the root is distal like that, then the path of removal is like that. It goes around in like a circle. So your movement should be like that. Try to push it. So you always look for a distal curvature and fused roots. That makes your upper third molars very easy. Okay, but then there's some thing which makes it very complicated sometimes. Some of the teeth are buccally tilted. Okay, they're completely looking buccally, and in that case it becomes very, very difficult because the path of removal is buccal. And then on the buccal aspect, many times there's your coronoid process, and that will actually block and make your extraction very, very difficult. So if you have a tooth which is looking buccally, be careful when you're doing that. And when you elevate, you try and do the pushing more buccally and occlusally rather than distally and occlusally. Okay, so look out for those buccally tilted third molars. Right. So what else makes it challenging? Sometimes they might have these slender roots. You see this root, it seems to be not ending at all. So when you try and remove it, it'll come, but then you hear a small crack. You can be sure that this very thin part of the root might break. Okay, so we get to when we can leave roots behind in some time. Okay, and this was another interesting case I had. He actually was one of my friends. Okay, he was a friend's friend and referred to me because he had apical periodontitis for his upper third molar. So we tried looking at the tooth. It just had some buccal tilt to it, and then there was a filling present. Okay, and when I tapped, it was tender. So I tried convincing him that a filling can do the job, but I think he was moving out and he was going abroad, so he wanted it removed. And he is only 6 feet 6 inches, so he's a big man. Okay, so the good thing is mouth opening was good. Okay, so I tried to extract it with using this X-ray, and after I removed the tooth, I realized that 2 of the roots have broken. Okay, so if you can see here my notes, this is important when there's a fracture. So mention what happened. So the distobuccal and palatal root had fractured. So 2 roots came out, but 2 roots still there. And imagine this kind of slender, long roots in a person who is 6 foot 6. Okay, so he's my friend. So I told him I have to go in and get it out because it wasn't too small. They were more than 3 to 5 millimeters. So I did go in and I could see the interradicular bone. So I removed the interradicular bone and then I managed to get that out. And then I had to place a suture. So when the roots are slender and long, you don't know how they can be. And even though I have an X-ray, there's no way from this X-ray I could say that this tooth had 4 roots. Okay. And in some cases, I decide to directly open. Say in this case, you can see that only a part of the crown is left and it's gone subgingival. The caries is subgingival. So if I try to elevate, this part will break. And then anyways, I need to open it up. So from the start, I'll tell the patient this has to be open and break it because the level of the distal bone also is quite high here. Okay, and then you have cases like this where there's a mesial curvature. So we kept talking about how important the arc of rotation is or the arc of removal is. So for this, for all other teeth, we spoke it's like that. So that's why you put your Warwick James and push. Here, the place where I put my Warwick James already has caries and also the root has a mesial tilt. So for this, the path of removal is like this, which will obviously be blocked by the 7. And there's no instrument for me where I can engage distally and push it like this. That doesn't happen. So this one, I'll have to slowly try and remove with forceps. I have a case like this and I'll tell you what happened to that case. Okay. And this kind of case really is difficult. Okay. For me, when I want to show off, when people don't know what the root is like, I can show off with what I showed you previously, those fused conical roots going distally. But if you see something like this, obviously this is going to take a lot of time. This is a 40-something male, 40-year-old male, 45 maybe. I don't remember exactly. So it's grossly decayed. Lots of distal bone behind this. Okay. And the roots have different patterns. And I don't know how many roots are there. And also the sinus looks very close. Okay. So in this case, we obviously, I think, open it up later everything went well with this, but it is quite challenging for us. Okay, so till now, I've just addressed the problems and questions that we had till now. So this completes me talking about extraction of all the teeth and the challenges and how to probably deal with them. So before I address the other questions that you guys have asked, there's quite a few of questions that you guys have asked. Can I please know if there's any doubt about the things we have spoken till now?
Yeah, so everyone just maybe if there's doubt, just raise your hand. If there's no doubt, maybe you can type 2 so that Dr. Naveen can proceed. All right.
Okay, no doubts as of now, right?
Yeah, I think 2. I think we can proceed, Doctor.
Okay, okay. So now we go on to address the other questions which were sent to us. So what to do? Can you see the question? Because mine is blocked here.
I can see, Doctor.
Can you read that out for me?
All right, sure. What to do when maxillary tuberosity fracture during extraction of upper 8s?
Okay, great. So it's a good question, and it does happen very often. And you can't blame yourself if you see the tuberosity attached to the 8. Okay, that's because it was fixed to that. So you can't do that. It's attached to that, and both of them come out together. It's okay. Okay, so what can you do is use less force, like I told you, not to use your cryers, and maybe Coupland, if you know how to use well, is okay, but obviously try avoiding the cryers and use minimal force for that. So if bone is already fused, you have no choice, it will break. So once it breaks, 2 things determine what you do with this. One is how big the fractured fragment is. If it's a big fragment, then you probably will be worried about it. But if it's a very small fragment, it's okay to just remove it and then suture the socket back. And the more important aspect when it comes to fractured tuberosity is the attachment of the periosteum. So is the periosteum attached or no? If the periosteum is attached, you obviously put it back and then you suture it and then monitor how it heals. Okay. So many times if the chunk of tuberosity which is broken, if it's too big, then it can actually lead to oroantral communication as well, in which case you again want to put the bone piece back. But if it's small piece, small fragment, then you can remove it. If it's a big fragment, periosteum still intact, you just put it back in place, tight figure of 8 suture, then it should be okay. It will heal, okay, because the maxilla has good blood supply. Okay, and then like I told you in between, you can see here again a long-standing edentulous area. The sinus comes down. It's more common than you think. So you obviously have to watch out for that. So the question was how to identify if oroantral communication has occurred and what to do when faced with oroantral communication. Okay, so if you read books, they explain this maneuver called the Valsalva maneuver, which I personally never do. Okay, the maneuver actually requires the patient to close his nose and then blow air out. Okay, so when he does that, according to them, what happens is if there is a oroantral communication, the air, instead of coming out through the nose, because you've closed your nose, comes out through the communication. Okay, so this is something I never do, but if you read books, this is the one technique they show you. They say you can also place a mirror, and then if fogging of the mirror, it shows that air is coming out. Okay, so many times when oroantral communications occur, right, there's always a thin layer of bone or mucosa there, or even your clot which forms can sometimes seal the communication, unless it's a big communication. Pinpoint communications can heal like that. So one thing I don't do is ask them to blow, which might make the communication bigger. Okay. The other thing I don't advise also is for you to take your probe and say, I think there's a communication, and poke. That surely again, it will disrupt the small or the thin layer, and it could have healed. It won't heal once you poke like that. Okay, blowing, poking, even though books say that, I don't do that. What I normally do is I ask the patient to take some water and rinse in the sink. Okay, if there's an obvious oral-antral communication, when the patient goes to the spittoon to rinse his mouth, puts his head down and puts the water out, they will feel the water getting into the nose. Okay, it goes to sinus and comes out through the nose if it's an obvious communication. If that's not happening, what I do is maybe put some hemostatic agent in the socket and put a nice figure of 8 suture, by which I'm making sure that the clot doesn't get dislodged. Okay, I hope that's clear to you. I don't like asking them to blow, because that itself can make it a bigger communication, or I don't go poking. When I suspect it's there, I just ask the patient to fill water in their mouth and then spit. So I observe if any water comes out or they have any abnormal sensation. And then if there's nothing like that, put a figure of 8 suture just to make sure the socket, the clot doesn't get dislodged from the socket. So that's what you can do. But if you know you have a communication which is very big, so first thing you can do is do like a buccal advancement flap. Okay, so I'll have to draw again. I hope this thing works properly now. Okay, so imagine you have a socket. Okay, so this is your buccal bone. This is your palatal bone, and you have an opening there. So what you can do is something called a buccal advancement flap. Okay, say we are talking about a premolar in this case. Okay, so this is your communication. Okay, so you can trim a part of your buccal bone. Okay, and then this is your view from the top. I'm trying to show you from the top. What you can do is make 2 release incisions here. Okay, let's have the other teeth here. Okay, so on your mucosa or gingiva, you make an incision like this. Okay, trim some bone and you pull the mucosa and suture to the palatal mucosa. Okay, so you pull over this and then you suture it here. Okay, so that's called a buccal advancement flap, and that's the simplest one which even you can try. So this can be done in very simple cases when you know it's happened and it's a big communication. Okay, so when you can't do this, if you need help, you obviously will have to refer. Say if it's in the molar region and it's a chronic oroantral communication, you actually have to check if the sinus is clear before you do this finer closure. But if it's immediate and you know it, if it's in the 7 and 8 region, you also can use the buccal fat pad, but then that would require you to refer the case to the maxillofacial surgeon. So the simplest way of dealing with it is by doing a buccal advancement flap. So you can raise this flap. If you can pull it all the way, you probably don't have to trim the bone. If you can't pull, trim bone to a certain amount and then pull over and then suture. So then that will heal as well. Okay, so that's what you can do when you have a oroantral communication. Okay, so this is a very, very interesting question, and there's answers for this. Okay, and there are specific times at which you can leave the root behind. Okay, and in my time in IMU, unluckily I've had 2 cases in which I had to leave behind the roots, and I still don't like it. But then if you see the x-rays, you'll understand why that happened. And there was no choice. I had to leave them behind. So let's look at this case. So this patient came with some pain in the lower 3rd molar area. Okay. And then she's 40 plus. And for this 3rd molar to act up at this age, I thought is quite unusual. And then we took an x-ray. There's no periapical lesion. and you see the root. If I tried extracting this, I probably would fracture this root, and it's very close to the inferior alveolar nerve. So then the reason we found out why she was having pain is because the upper tooth was impinging on this. She had some soft tissue cover and impinging on this. So I thought, knowing how close this is to the inferior alveolar and chances of this fracturing, we thought it's a good idea to extract the upper tooth, because once the upper tooth is extracted, there's nothing she'll be biting on and the pain will get relieved, which is what exactly happened. But the extraction of the upper third molar didn't actually go to plan, because if you see this x-ray again, like I told you, I don't know how many roots are there, but I see like a circle here, but I didn't know what to make of it, because unless I do a CBCT, I can't make out. But doing a CBCT costs patient to pay so much money, and it's not going to change the outcome. So I did the extraction and I heard a crack, and then you can see when I took the x-ray, there's this, you see the circle here. So the same circle is still here. So I definitely know that the root is broken and it's here. And for this patient, I did try to see the root. I could see the root. It wasn't mobile, and there was no way I could get to it, because the 7 was making accessibility and visibility very hard. And I wouldn't want to go in and try to do anything, because if you see the line where the sinus is, half of the remaining root is above it and half is below it. So when I can't see anything well, and I try to do something with this, there is a big chance that I push this into the sinus, which I didn't want to do. And I did discuss with the patient about the risk of this getting into the sinus if I did try. And we could try and leave it like that and monitor it and see how it goes. So the patient obviously chose to just leave it. Okay, so the important things when you leave the root behind is sometimes it does break, and you don't know what to do, because this one was hardly visible, and there was no way I could access this. There was no way. I tried very long, so I left it behind. So what are the criteria you have for which you can leave the root behind? First is, it has to be 1/3 or lesser than that. Okay, so I think this is about 1/3, so it's not too big. So that was one criteria. The second one is, it shouldn't be mobile in the socket. This is very big. I have seen so many people ignore this, and the patient will always come back with some problems if the root which is broken is already mobile. Okay, so one is, it has to be really small, it shouldn't be mobile in the socket, and there should be no symptom for this tooth before, like no periapical pathologies. Okay, so this patient, we removed this to relieve the biting caused by this. Okay, so there was no periapical pathology. So these are the reasons or the criteria for you to leave the root behind. One is, if you're unable to retrieve, you're unable to see, if it's very small, and then if it's not mobile and there's no periapical pathology. If you can tick all of these, then you can leave it behind. If you can't tick all of this, you have to remove it either yourself or get help to remove it. Okay, so this one, I did call one of my colleagues to see if they could remove it. So it's not like that I didn't ask for help. I did ask for help. They did try for a lot of time, and they couldn't even see it. I could see it because I probably was doing the case and I knew where that root was. My colleague couldn't even see it. So we both discussed and said, okay, this is not going to work, and we left that. And luckily, I've been following up on this patient, and the patient didn't come back with any problems. Okay, so this can happen to anybody. And look at this one. So I showed you the other case where the root has an unfavorable curvature. So this is what I was talking about. So this one has a mesial curvature and not distal curvature. So as soon as I saw this, I knew this is going to be tricky. And the patient had decay, so had pain, and also I think had cheek bite, so wanted this out. And after I tried to remove, the tooth moved after a while, and then I used the forcep to finally extract, because with my Warwick gems, it's moving, but it's not coming out for a long time. It's moving, but it's not out. So finally I held it with a forcep and removed it. And then, yes, so if you can see here, that unfavorable part of the root, the tip, got stuck over here. So in this case, it was quite easy for me to leave it behind because I couldn't even see it. And if you can see on the x-ray, the root tip is literally almost in contact with the 7. So I can't go in, remove any bone and remove this at all. So in this case, again, I did ask for help, and my colleague also couldn't help me. So we tried to leave it. I mean, we left that like that. And we put this up in the notes that there was a fracture. And then we've taken an x-ray showing the fractured root, patient informed, patient consent taken for leaving it behind because we can't even see it right now. And we followed him up regularly to see if he had any problems. Luckily, he didn't have any problem. Okay. So again, the criteria are when you can't retrieve it, you can't see it, and then it's not mobile, and then it shouldn't have any periapical pathology, and it has to be quite small. Okay, so that's when you can leave it. And yeah, luckily I managed to dig out the 2 cases where I left the roots behind, and luckily I know them, so they're still okay, and I hope they don't come back to me because I wouldn't know what to do if they had some problems. It's been quite some years now, and I hope I don't have to see them for this. Okay. Another common question was, can extraction be done when there is an infection? Okay, so when we talk about infection, it could either be a chronic infection or a acute infection. So if you're talking about acute infection, there are many challenges if you want to extract the tooth. Firstly, being your block not working. So if your block doesn't work, you can't extract. So that's when you probably have to start the patient on antibiotics and wait for some time and then get them in. But what I do is, I always believe in this, okay? And for all of you, I think you should remember this, that as long as the source of infection lasts, the infection is going to last. The best treatment you can give somebody with an infection is to remove the source of infection. And if you think of what the source of infection is, in this case, definitely the tooth. So the earlier you get the tooth off, the better for the patient. So what I try to do is, however the infection is, I try to keep the local anesthesia. If it works, then I try to get the tooth off as soon as possible. But it's a different case. If it's already led to a space infection, the patient goes to the hospital, he'll be taken under GA, and we do the same. So remember, anytime you have an infection, don't just send the patient away. The earlier the tooth is removed, the best, that is the best treatment. So just try to get the source of infection out. The source of infection here is the tooth. So if your block works or your injection works, you just try and get it off. Okay. But when I encourage you to get this off, you also have to remember, if the block is not working or injection is not working, you can't do anything. So you'll have to send them back with antibiotics. And if you have a vestibular abscess and you're dealing with teeth which just need infiltration, please avoid injecting into the abscess or into the vestibular swelling you have. Okay, so don't put the syringe there because there's no point putting it there, and maybe you'll inject there and you'll again infect another area when you use the syringe again or the needle again. So avoid local infiltration in the area of infection. When possible, just use nerve blocks while doing these extractions. Okay, so this is a picture of a patient who has chronic infection. So you can see chronic infection is good for us, for people who do extraction, because a patient has less pain. They would have tolerated it for a long time. When they come, there's hardly any bone, and extraction is very easy. But you don't need an expert to remove these kind of teeth. The one thing which I hate when people don't do is curate these sockets properly. Okay, so it's just easy for you. You have no nerve or vessel here, so you can go all the way down and curate this. Okay, if you leave behind that granulation tissue, the body has to do all the work to get it off. Okay, so you are in there, you've extracted in no time, So go in and just remove all the soft tissue. It bleeds a lot. It's annoying, but once you remove everything, you have to see proper bone there. Don't leave soft tissue in the sockets. Okay. So it's very, very important. Don't take curettage easily, because for this extraction, you don't have to be an expert. Okay. Another interesting question, which I have my own take on, is if you have to remove your upper edge whenever you extract your lower edge. Sometimes you have patients themselves saying, I've read in the internet, or somebody's advised them, or their cousin had it like that, so just get the upper edge out. I don't do it when I think it's not necessary. So in what cases is it necessary? So it's necessary if the tooth is already supra-erupted. Okay, many times when you have impacted teeth, the upper eight is already supra-erupted, and it will actually be causing indentations on the buccal gingiva or over the operculum. So in those cases, yeah, maybe you can think of that. And if it's too buccally erupted and causing some trauma, you can do that. Or if it's already got deep caries, then you can actually go in and remove that. But if it's a tooth which is harmless, it's sitting there quietly, I don't think you need to extract it every time. I mean, I've seen patients for years, they don't have problems. Okay, so it's your call, but I really think we shouldn't be extracting teeth just for the sake of extracting, assuming it will supra-erupt and cause trauma later. Okay, so another question, should we give pre-op analgesics for normal extractions? I don't think it's necessary. Okay, and when to give antibiotics is a big chapter by itself. In short, for any extraction, including when there's an abscess, periapical abscess, you don't have to give antibiotics. When I do give antibiotics is if I've started off with the case thinking it's normal and it ends up being open extraction and it goes on for a long time, which is very, very rare, that's when I give antibiotics. Otherwise, for normal extraction, it's not recommended at all. Okay. So contraindications for extraction. So somebody's asked, how high can the BP be for you to decide I won't do the extraction, and how high can the blood glucose be? So I'll address the blood glucose one first, because for blood glucose, there's no level for which you need to stop extraction. You actually can do the extraction however high the blood glucose is, but then you know that the healing might be bad. Okay, so it depends what situation you're doing it. If it's a normal extraction for a patient who just has pain or some discomfort, or because of periodontitis, I'll use this excuse to motivate them to go see a physician and get their blood levels under control. But if it's an emergency, it's a space abscess, say it's a Ludwig's angina, that case, however high the blood glucose is, you can get the tooth out, because it's already, like we discussed, when you get the source of infection out, it also helps in kind of balancing the blood glucose level as well, because the general condition of the patient improves when you get the tooth out. So for this, the answer is emergency, the blood glucose level doesn't matter. Elective, I just use that as an excuse to send them to the physician, because I know when I extract, it might not heal properly. So if it's not an emergency, maybe it's good for the patient to see the doctor. If they are long-standing diabetics, taking medication and still the blood glucose level is not under control. Okay. For blood pressure, there are few criteria you have to keep in mind. If it's surgical, then surely you can't do surgical or a difficult extraction when the BP is more than 160 over 110. Okay, or 160 over 100. I think in IMU, we all had this consensus that if it's a 160 by 100, we wouldn't attempt difficult extractions or surgical extractions. But if you read the guidelines, I think the few guidelines which mention 180 over 110. Okay, 180 over 110 is the level after which you have to defer any invasive treatment. So in short, 160 over 100 for a person who's not hypertensive, you didn't know, is still okay. But if he's hypertensive, he's on medication and still it's so much, when you start doing something, the BP will still keep going up. So 160 by 100 should be your limit for taking a risk in your clinics. Okay, so another question is how to stop bleeding if it's excessive. So for normal extraction, your bleeding should be able to stop with normal pressure, okay? Pressure and hemostatic agents. So you might put in some gel foam and then suture that area and just press and keep. And for normal extraction, that should be enough, okay? If it's bleeding more than that, there's probably some systemic disease and you have not, that you have overlooked. So pressure hemostatic is enough for most normal extractions. Okay, so we've discussed all this, but I want to stress on some cases which are likely to end up as surgical anyways. Okay, so if you see cases like this from tomorrow, you do consider opening it up in the first place. Okay, is it a good idea to do that? I have seen it's a great idea because if you start out like a normal extraction, firstly, the patient is expecting it to be a short procedure. So you start off, then it turns out to be a surgical. You tell them midway that now I have to do a surgery, and then it takes so much longer. By then, the patient has lost energy. You have lost energy, both physically and mentally, and you can't work properly. So next time you see cases like the ones I show you now, maybe it's a good choice to just do them as surgical extractions from the beginning, because you can get it done very quickly. The patient knows what's happening and the healing also will be good. Okay, so if you see x-rays like this where there's no PDL space, okay, no PDL space at all, and cortical bone, middle-aged men or women, then high chances of these getting ending up as surgical extraction. So you try luxating them. If they're not getting luxated, I think it's a good idea to open up. So because even after you drill bone, you'll see that these teeth are quite a challenge to come because they have no PDL space around them. Okay, and this case which I told you, if you see bulbous roots like this, you know it's going to break. So you just warn the patient, tell the patient, and then open up and then do it. Okay, and if you see cases like this, many of your root canal treated teeth, I don't know what the association is, but then end up having no PDL space. You see, compared to this premolar here, this molar has no PDL space, and there's already root canal treatment done. So if you try to hold it, if you try to luxate it, it won't get luxated or the crown might fracture. And then to get the roots out, you have to open it up. So these cases also nowadays, I try to warn the patient that most probably this will be surgical. Try for some time, then immediately open it up. Okay, this is another root canal treated teeth. Okay, so where you can see in the crown fractured, and I removed the roots, and I think I was unsure about one of the roots, so I did take an x-ray to double confirm if I have removed everything, and yeah, I had removed all the roots.
Dr. Naveen, so I think should we stop soon to open the floor for Q&A?
Yeah, I just have a couple of slides and I think we're done.
Okay, all right.
Okay. And then there are patients with cardiac issues and a long medical history. So this patient came again, as you see, no PDL space at all. And I took, I think, about 2 hours plus to remove this. He was somebody in whom the buccal cortex was, I think, 2 to 3 millimeters thick, and it took a long time. And for this patient, I knew this is coming because I did take his history well, and he has history of difficult extraction. So any tooth he extracts, it's difficult. He says none of his teeth have come out without surgery. Okay, so it always goes on for 2 to 3 hours. So it was the same in this case. So always take a history. If a patient says they had a history of difficult extraction, you probably are going to end up with that if there's radiographic evidence. So what to look for in a radiograph? The root pattern, very, very important. The root size, okay, the surrounding bone. And again, to stress on that, PDL space, okay? Always think about the PDL space. And then You also look for any pathologies and proximity to sinus and the nerves. Okay. So this is another question: when to ask for help? When you think you can't do anything good for the patient, that is, or you think you're very tired, then that's when you have to refer. Anytime you call a new or a fresh pair of eyes or a mind, maybe you're just pushing it the other way, the other person comes and pushes the other way, it'll come out. So when you think you're done your best and you can't do any more, that's the best time to refer, or you think it's beyond your limit. Okay, so we all have bad days, and we all take help at some point. So when you think you're affecting the patient's well-being, it's the best time to refer. Okay, so this is the last slide for today. So before we go, let's look at these key points. Okay, so never pull out a tooth. This is a mistake which most people do. They hold the tooth with a forceps and always try to pull. Don't pull. You always have to remember we're holding the tooth on the root and then giving a apical force. You actually push it back in the socket, because expansion of the socket is most important. Okay, so do that. Don't pull the tooth until it's completely luxated or mobile. Okay, and look at the PDL space in the x-rays. It makes a huge difference. And one thing I want to stress is luxation is overhyped, whereas good reflection is not. Good reflection is as important as luxating the tooth properly. Okay, choose your instruments and use them properly. You should know what to choose for what case and how to use it. Okay, and then as long as you know what to do, you have a plan and you can execute it. You execute the case, the plan well, every case will be easy. So it needs proper planning as well. Okay, so good luck. And I hope tomorrow when you go back to your practice, you don't look at your patients or your x-rays the same way after having been in this talk. And I hope this helps you in any way possible. Okay. And I also want to thank all of you for being a part of this, and thank our dental chapter members, Raviran, Eunice, Celia, and Janyan, for doing a great job in organizing these talks. Thank you all so much.
Thank you. Thank you so much, Dr. Naveen, for that in-depth, comprehensive, and a delightful session. I think in that session, we covered techniques for each tooth type, how to recognize complication, and also how to enhance success rate of LA. So Dr. Naveen, Dr. Praveen say a good point is, I think it's not extraction 101, doctor, it's an extraction encyclopedia today. Yeah. So thank you so much. I think the only regret is tomorrow is a Sunday and I cannot put all these tips and tricks immediately into practice. All right, ladies and gentlemen, so Dr. Naveen has spoken for 2 hours. So let's give him about 5 minutes for a breather. Meanwhile, we have posted the feedback form on the chat box. So for alumni, please fill this up and you'll be getting a certificate. Even for dental student, yeah, do fill it up so that we know what are the topics that might interest you, and we will try to make that happen, right? Because this is what alumni is for, that we are all here working for you. So while waiting for the 5 minutes breather time, we'll just take a good picture. So Eunice would help, you are the photographer today. And everyone can just turn on your camera here and let's take a good picture. Come on, everyone. Don't be shy, everyone. Hi, Nicole, Jacqueline.
Hi, Doctor. Thank you for the much needed lecture. We are struggling in our clinic.
I just hope you all can use whatever we spoke about today. Maybe that will change things.
Yes, I'm working tomorrow. I'll definitely apply it tomorrow for my outpatient.
Yeah, guys, let's open your camera. We'll just take a good picture. Like Dr. Praveen, Jimmy, Chun Fai, Michelle Chua. Yeah. Oh, Dr. Naveen, you have a lot of fan club. I saw like Dr. Naveen fan club 1, fan club 2. I love Dr. Naveen. Dr. Naveen is my love. Yeah. Yeah. Eunice, can you? Eunice, are you there?
Okay, done.
Done, huh? Okay. Thank you so much. I think, is it okay, Dr. Naveen? Do you want to proceed to the Q&A now?
Yeah, let's do it now.
Okay, all right. So I'll close the floor for the Q&A. So I'll just answer the question that are asked during the session. All right. Let me see. Because you have covered quite extensively, and I think it answered most of the question. I'll just see if there's any uncovered questions. Okay, yeah, Dr. Naveen. So this is one question that actually I encountered also. Is asked by Yi. Her question was, "Hi, doctor. How to remove the fractured mesial root of upper or lower second molar, especially when the first molar is blocking and we can't see the second molar root?"
Okay, okay. So that's a good question also. So I showed how to do a open extraction, right? So can we go to that whiteboard if possible?
Yeah, sure. I'll share the link.
Yeah. Yeah, that's one of the most challenging ones to do also. That's a good question.
So guys, if you have question and you want to draw it out to better ask the question, you can go to this whiteboard link and draw it out also. Yeah, Dr. Naveen, so you can go to this link right now.
Yeah.
And then you can share the screen.
Okay, I want to that. And let me share the screen. Okay. Yeah. Okay. Can you guys see my screen now?
Yes.
Okay. So let's draw. So we. So we're talking about the mesial root of the second molar, right?
Yes.
Okay, so say that's fractured there. Okay, so that's what the question was. So what we'll have to do is obviously open this up, give an incision and raise a flap. Okay, you raise a flap there and you expose this bone. You don't know where the root is right now. So all this bone will be intact. So you have no choice in this case but to go and remove the bone. So what you start your bone removal here. You start at the mesial of the socket, remove bone, remove bone, remove bone, keep going until you see the root. Okay. So you eventually see the root and then you can remove more bone. Okay. Remove more bone and then put the small elevator there and try to pull it out. Okay. So no choice when you have a case like this, when small root piece is stuck, you go in, start from the top here and then keep removing the bone all the way down until you reach the root tip and then remove bone over the root tip as well. And then you can push it out with the root pick elevator or sometimes a crier or a periosteal as well. Okay, does that answer the question?
Yeah. I think very clearly we know how to approach these kind of cases now. All right, Dr. Naveen. So next one is by SS, asked about tooth 1-8 with 4 roots curved in different directions. Fractured the root between palatal and distal buccal too far behind. Couldn't visualize properly. What to do?
Yeah. So I told you my own experience, right? So sometimes if it's very small, just the 1/3, not mobile, you can't visualize, no periapical pathology, you just leave. But if it's not fitting into all these criteria, you just ask a colleague for help. Maybe they can come and remove it. So let's see. So say there's 4 roots, right? And they all are in different directions. So say this is a buccal and this is palatal side. So you, again, here the idea would be to remove this bone and then try to get one of them out. Okay, once you get one of them out, then you can work on the interradicular bone and then you can try to get the other roots well as well. But then this all depends on the fact that you actually can see it. Like we just spoke, if there's a second molar, you probably can't even visualize it. Then you can't do anything about it. Okay. Yeah. So as long as you can see it, you try and do something about it.
Yeah. All right. Thank you, Dr. Naveen. I mean, I think if for me myself, if I saw a 1/8 with 4 rows, I'll just take emergency leave and go home. Okay, doctor. So Athena asked one question is, Dr. Naveen, have you encountered any case of patient complaining of prolonged numbness for about a month after getting local anesthesia with a computer-controlled local delivery system? Or I think in that case, after any LA, has there been incidents of prolonged numbness?
Yes, I've heard of it. Luckily, I haven't personally encountered that, but I have heard of people having pain and trismus for some time post local anesthesia, especially inferior alveolar nerve block, and also heard of patients having some numbness. Okay, so with computer delivered, if you're just giving intraligamentary, I don't think that can happen. But then if you're giving an inferior alveolar nerve block, many times you could have, your needle could have poked the nerve itself or injured the nerve itself. So that's why if you read Malamed now, he doesn't even discuss non-aspirating syringes. He said we shouldn't be using non-aspirating syringes. So you use a proper aspirating syringe, so you know if you're close to the neurovascular bundle and you can be careful. So I don't know if proper aspiration was done and maybe the nerve itself was injured. So I've heard of those complications happening. It's probably because the needle has caused direct injury to the nerve.
Okay, all right, that's very clear.
But if it's intraligamentary and it's happened, I don't have an explanation.
Dr. Naveen, so Dr. Praveen asked, thanks, Dr. Naveen. I learned many things today. Curious to know why is it tighter extractions 101 by Dr. Praveen?
I think Viren should answer that.
Yeah. Okay. Yeah, does Viren wants to answer? Yeah, this is his idea actually, the topic. Okay. Dr. Naveen, so there's this question by Yi. Doctor, I feel curved Warwick James has a flat handle which is difficult and painful to grip when we use it forcefully. How to overcome this? I mean, if the Warwick James handle is round, does it still works?
Yeah, I mean, I think most Warwick James have flat handles, though. So I think if you're holding it properly, it's actually cushioned in between in your palm. So I don't think it should be difficult. So you hold it like that. Okay, so imagine you holding it like this. I think because of my background, you can't see it. Yeah, like this. This is how you should be holding a Warwick James, and push it like that. So it does hurt sometimes here, I agree. But then, yeah, when the tooth comes out, that happiness will make you forget the pain, I guess. But it's not too painful. I don't think it should be too painful.
Yeah. I think it's true that when the tooth come out, all the pain are worth it.
Yeah.
All right, so sorry guys, due to time constraint, we'll just fill one last question. This is by Nicole. So doctor, if we don't have the lower American third molar forceps, is there any way we can modify the technique with a normal molar forceps to remove a lower third molar? Because it's true that she says it's difficult to engage properly and at right angle with the forceps that we have.
Yeah. So the forceps is just designed for teeth which you can reach. So one thing you can do is you can ask the patient not to open very wide. So when the patient opens very wide, the cheek becomes very tight. That's when the forceps can't go. So if the patient already has a good mouth opening, then you can ask them to close little so the corner of the mouth becomes loose, and then you can take the forceps back. But if it's somebody with a small mouth opening, yeah, it's very difficult. I agree. So if it's big mouth, ask them to close little. Once you have gripped the tooth, that will help you get to the posterior region.
Okay, that is a very neat trick, just to ask them to close the mouth slightly, right?
And especially when we're giving upper local anesthesia, right? We always make this mistake of asking them to open wide, and then you feel it's so difficult to retract. the easiest thing is to ask them to close a little bit, giving your
Yeah.
injection, so that you can go all the way down to the vestibule.
Yeah, I think sometimes less is more.
Yeah.
Yeah, I think yeah, thank you, Dr. Naveen, for answering all the questions. If anyone have anything to ask directly, really just feel free to unmute yourself or raise up your hand. Okay, if not, I think, Dr. Naveen, do you have anything you want to say?
So I just hope that this has helped them, and I don't want people to attend this and go back and see the cases exactly the same way you've been looking at it, and especially the radiographs. Okay, the radiograph gives away everything to you. So I hope this has helped everyone, and I'm so happy to see these familiar names. So I hope to see all of you sometime soon when this COVID thing is over.
Yeah, everyone, please stay connected with us through IMU Alumni. We'll always be part of this big family. And we also have exciting events coming up like the IMU Alumni Homecoming. So really just stay tuned for that. And with that, I just want to say thank you to Dr. Naveen on behalf of everyone here for such an, yeah.
Please activate your alumni portal. There's good things coming up on that. They've sent you an email many times.
Yeah, I'll activate the alumni portal, right? This directly from Dr. Naveen. So besides that, I also want to thank those that are working tirelessly behind the scenes, Riren, Wenxin, Eunice, and also Alumni Relation Office, Angela. So she was a non-dental personnel. So while all of us find this very interesting, she's probably having a very nightmarish 2 hours watching all this gory stuff. But at least I hope that motivates Angela to take good care of your teeth. Yeah, so with that, I think we have a great 2 hour, and the